Hi there, and welcome to this webinar on the OPED Australia LMS. I'm Lainey Plummer. I'm an orthotist, and I'm also part of the technical orthotics sales team at OPC Health. Today I'm presenting Programming the Allard Functional Electrical Stimulation System to achieve optimal outcomes for patients with foot drop. Let's get started. The agenda for this webinar is to introduce FES and the ALFESS in particular, perfect candidates, setting up the device, positioning it, programming it, discussing prescriptions, and also troubleshooting. What is electrical stimulation? It's a technique used to elicit a muscle contraction using mild electrical impulses. But what is functional electrical stimulation? Well, that's using those electrical impulses to elicit muscle contractions that cause a functional action. So, for example, with lower limb FES, we're looking at creating a dorsiflexion movement through walking, which will clear the foot through gait. In terms of an upper limb FES system, we would be looking at stimming the extensor muscles in the forearm to open the hand, which would potentially turn a handle, move something across a table, or open up the hand to then grasp onto a product or a device. ALFESS is an acronym for the Allard Functional Electrical Stimulation System. It is obviously a device to prevent foot drop. It stims the common peroneal nerve, the deep and the superficial branches, which we'll talk about later on in the presentation. And in turn, we're recruiting the tibialis anterior muscle and peroneus longus and brevis to create dorsiflexion and eversion, respectively. And the goal is to aid functional gait pattern by lifting and everting the foot. The device uses a tilt sensor similar to a phone. It recognises where it is in space, and the stimulation is determined by this angle, or by the angles created by the leg. The electrodes are integrated stainless steel electrodes. They're non-movable, and they're designed in a way to innervate muscles best based on the average leg shape and average nerve pathway. They stim all at once, so you cannot choose which ones stim and which ones don't at one time. The device is splash proof, and it is actually a closed or contained unit, which does have some pros and cons, which will be discussed later on in the presentation. It runs on a rechargeable lithium battery. Some simple features here. You've got your power on and off button and an LED display in the center of the device. The arrows are indicating intensity or amplitude of the stim. There's a charging port at the base of the device in this picture, and you've also got a Velcro and additional magnetic clip for donning and securing the device around the calf. The ALFESS is a one-size-only device, which is suitable for left and right legs. It fits most adults. Each kit does come with an extension strap for bigger calves, and the strap has that magnetic clip to assist in one-handed donning and doffing. There is no heel contact switch, which is actually great for barefoot walking. And as discussed, the device is completely contained, which allows it to be splash resistant, and it does have a waterproof certification. However, this also means that we can't actually open up the device to do servicing on it, as that it would then void that waterproof certification. So there isn't a servicing as such. We're certainly able to bring in the device and do testing on it, but we're not able to open it up and fix it. Identifying perfect candidates for FES. So obviously we want a patient who presents with foot drop. In our OPAL clinics, mostly we're seeing diagnoses of upper motor neuron related diseases, and our percentages or ratios are looking at similar to a 65% stroke population, around 25% multiple sclerosis population, and 10% cerebral palsy. I would say that more recently the multiple sclerosis population has increased and potentially stroke has decreased a little bit. We're trying to find patients who are motivated to try something new. So having that FES or that stimulation, electrical stimulation feeling on the leg can be a little bit uncomfortable and certainly something new in a lot of people's lifestyles. So if they're motivated to try something like that, fantastic. Also, cognition and ability to use a phone is quite important. The ALFESS does have a remote control, which you would have seen the picture of at the beginning, but it's most commonly programmed or turned on and off via a phone app. So it's quite important that the patient's willing to do that or have that control. Contraindications or patients for consideration that may not be a perfect candidate are patients who are living with lower motor neuron related diagnoses, such as your Charcot-Marie-Tooth patients. They may look like perfect candidates. However, due to the damage to the nerve, they're actually not candidates for ALFESS or FES. Patients who have traumas or nerve lesions, and these are generally patients who are post-radiation as well. Again, we need to consider the cognition and ability to use a phone. Unfortunately, we have had a case where we had a patient who had a fantastic result with their ALFESS device, however, was really struggling to program it or just turn it on and off, and logging into that app on the phone was just quite difficult for that patient. Let's move on to positioning the device. A quick brief anatomy lesson for us all. Here are the landmarks that we need to be familiar with on the leg when positioning the placement of the common perineal nerve. So we want to know where that fibular head is. And then let's look at the common perineal nerve and how it runs from the posterior aspect of the leg or the popliteal fossa. It runs anteriorly towards that fib head, and then it branches into your deep branch, which runs anteriorly to innervate the tibialis anterior muscle. And then it also branches off into a distal direction, which is the superficial branch, which is going to innervate the perineal muscles. The ALFESS works by innervating the common perineal nerve branches. Deep branch is stimulated by that one large electrode, and that activates the dorsiflexors, so tibialis anterior, extensor digitorum longus and brevis, and extensor hallucis longus. The 6 smaller electrodes are used to stimulate the superficial branch to get eversion by innervating the peroneus longus and peroneus brevis. The benefits of having 6 smaller electrodes is that it provides a much more gentle and comfortable stimulation over a broader space of skin, which makes it that little bit more comfortable. It also gives us a better chance of hitting that muscle, or hitting that nerve, I should say. Allard, who is our supplier of the ALFESS, encourages the use of a conductive gel wherever possible. However, we've had a few devices sent back to us with charging issues over time, so the battery is not charging to its full capacity. Generally, this is when grit and grime has built up in the grooves of, say, the charging port, but also a little bit around those electrodes as well. So it causes an obstruction of the flow of the charge. Generally, what we do, and this is what we would determine as a service, for example, of the device, is we would clean out the charging port and give the device a really good scrub and a clean. And then usually the device will be charging perfectly again after that. But it does seem to be those patients that are using gel that tend to get the grime build up faster and in more of a heavier nature. So all we ask is that patients maintain and clean the devices daily to avoid the clogging up of dirt, skin and grime. Some more positioning and electrode setup. This is a great image here, which determines small movements that you can make to really change the outcome of the stim. So if you're looking to create a little bit more eversion and knee control for the patient, You would just move the device slightly in a more proximal direction. If you're looking to get more eversion, you would twist it quite laterally. If you wanted more dorsiflexion and less eversion, you want to be trying to hit that tibialis anterior belly a little bit more. So moving it a little bit more central onto the leg and onto that tibant belly, that should allow for some more dorsiflexion. Again, if you need more dorsiflexion, you want to move it just a little bit more distally. That's a great reference slide. Another reference slide is here. So this is all about registering your name and logging into the app. The app is called Foot Drop Rehab, and if you've got any questions, you can certainly get in touch with us and we can run you through the registering and login process. However, recently the app has been updated and it is incredibly intuitive. It's really quick to log in. You just need a login name and a password. Please write that down. Now that you know where the device needs to be on the patient, it's time to learn how to program it. One big detail here is just to note that there are two modes that we're going to talk about soon. However, one mode, which is the Pro version, which clinicians will be using, that requires a password. The password is just here on the screen. It's 252700. Please, if you're going to be using the ALFESS, just write that one down and pop it next to your desk or on your desk somewhere so that you can use that as a reference in future. There are a few parameters that we need to be really familiar with prior to using or understanding FES and setting up a patient with this stim. So let's talk about the parameters that are most important and commonly used with the ALFESS. You're looking at pulse width, and pulse width is measured in microseconds. So another way that I like to look at the pulse width is the strength of the stim. I feel that this is the one that has the most influence on how strong the stim is and how powerful it is on the patient. The next one is frequency, which is measured in hertz, and that's how many stims actually happen per second. So if you have a low frequency, you're going to feel that it's a low amount. Sorry, it's a low amount of frequency, and you'll be able to feel each of those stims happening per second, and that also makes it a stronger stim or more powerful. But if you want it to be more comfortable, what you do is you increase the frequency. And then that means that there are more stims happening per second, and it takes away the power of the stim and just makes it into more of a buzzing or a fuzzy feeling as opposed to quite an aggressive, strong stim. And then there's the intensity. So once you've balanced your pulse width and your frequency, you're able to use your intensity a little bit like volume. So in the morning, you may start your intensity off quite low. And when I say low, that might be 20 to 25. And then as your patient tires out or fatigues slightly throughout the day, you may want to increase your intensity. And then that may look more like a 30 or a 35. It's measured in milliamps, and that's the number that you'll see on the LED display of the actual unit. And you can also turn the intensity up and down on the phone app as well. There's a couple of little hints and tips and tricks there at the bottom. So if you are looking to increase your lift, you may increase the intensity. And if you're looking for a faster lift, you may increase that in frequency as well. The initial setup of the device must be programmed using a phone. So this may be the clinician's phone to begin with. Then when the customer is happy to move forward with the product, you may program the device with the patient's phone. In saying this, clinicians can actually program the device with the remote control. However, that would require another hour webinar. So if you would like to have more information on how to program using just the remote control, which I think if you're using the ALFESS at all, you certainly should get this IFU. But please get in contact with me and I can send you out the instructions for use for the remote control and how that can be used to program. Historically, iPhones are preferred for programming the device. However, recent updates and feedback from the field has been that the Android app has been working really positively as well. So as I mentioned earlier, there have been some updates, 8 updates to the app made recently, and it seems like it's all fairly smooth sailing, which is really nice. All right, so in the settings section of the app, you can choose the Lite or the Pro version. And we recommend that you go into the settings and switch the auto off time to 4 hours. In doing this, it just means that you're giving the patient the longest period of time before, of sedentary time prior to it turning off. So if the device hasn't been used for 4 hours, if there has been no stim happening that time, it will automatically turn off. The issue is that sometimes patients will have this set to 1 hour or 2 hours, and then they don't realise why their device is turning off, and then they might stand up, maybe just to go to the kitchen, or if they're at work, they may be going to the bathroom, whatever it might be, and the device has actually turned itself off. So we like to encourage that as soon as you get the device to program, switch that auto off time to 4 hours so that the patient's not at risk of having it turn off. You'll also see there that there is a beep mode. Obviously, if you're assessing a patient and you want to know when the stim is coming on, you would turn that beep mode on. Once you've finished programming, please turn it off. We do get quite a few patients ring up saying that their device has started beeping or that the beeping's turned on. It's really good to practice always turning that beep off after you've done your assessment, but then also being able to coach your patient through turning the beep mode off remotely if it happened to come on for some reason. They may need to log into the Pro version, hop into the settings, and be able to turn it off that way. We can always assist if you're having some trouble with that. Now, there's also a setting called prompt of stimulation. So if beep mode is annoying for yourself, or if it's annoying for your customer or client whilst they're working through their assessment, you are able to use prompt of stimulation. And that's when your phone will actually buzz as the stim comes on. So you should be able to feel, as you've got the phone in your hand, you should be able to feel when the stim is coming on due to that little slight vibration of your phone. And you'll know if the device and the phone and the mode that you're using for the programming is working accurately. So as I've sort of mentioned, you've got that patient version of the app, which is the Lite version, and then you've got the clinician's version, which is the Pro version. So let's have a look at what a patient can see when they're in the Lite version of the app. They're able to see 2 modes, the gait mode and the training mode, which we'll talk about shortly. They're also able to access a statistics tab. So this one collects data such as steps taken during the day, a little bit like a pedometer, and then it will also show daily average of activity as well. Training mode is fantastic for patients because it is simply a program where the device will stim on, off, on, off. And you can choose how long it stims for, how long the rest is in between, and then how long the whole session goes for as well. And the benefit is that there are 20 plus prescriptions that are preset in the app, and you can either choose one of those, or of course you can custom make a training program for your patient. I think these are best used for patients who are maybe having a quiet day. So they're not going to be doing much physical activity for that day. They don't have any walks planned or any outings planned. But they still want to obviously contract those muscles and ensure that they're keeping the range of motion in their ankle. So they can sit on the couch or on the bed, wherever they're comfortable, and turn on the training mode. And they may just sit there for 10 minutes or 20 minutes and have that stim coming on, going off, coming on, going off. And they'll be able to continue with that range of motion of the ankle and getting that dorsiflexion, keeping that muscle nice and stimulated and strengthening. Another fantastic reason to use the training mode is for patients, particularly our MS patients. They can wake up really, and stroke patients as well. They can wake up really stiff, and turning on the training mode will just give them time to sort of wake up those muscles, wake up the ankle, make sure that they've got that range of motion happening, that it's placing the foot and ankle into an everted position as well, so they're not going to stand up and potentially collapse into, that equina varus or supinated position. And if they have any swelling in the ankle or lower leg, pumping those muscles and moving the foot and ankle could potentially clear some of that swelling. So let's move on to the clinical programming, or the pro version of the app. As we mentioned, there is a passcode to access this, which is 252700. Write it down. And again, you're going to be able to see the gait mode and also the training mode. And we want to find the best location and the parameter settings by using the training setting. So once you're putting this on your patient, instead of getting them up and go straight away going for a walk, definitely put them on the training mode and have your stim coming on and off to ensure that you're getting the positioning right. And when you're ready for the patient to start walking, turn on the beep mode to know when the stimulation is coming on. There's several options for programming and also doing an evaluation of your patient's gait and then getting some recommended parameters for them. There's manual mode, which is manual stimulation in a treatment setting. This is literally pressing a button on the app to initiate that stim. It's very rare for people to use this. However, the original WalkAid 1 used this mode of stim programming, where you actually had to physically press a button for the stim to come on, and then that would lift the foot. There are still some people out there that like using this mode. However, I find it incredibly arduous and challenging to be able to get the stim to come on regularly and also accurately. However, there has been one situation where this mode was fantastic for a particular client. He was around about 40, 42 years old. He had had a stroke, and he was prior to the stroke, he was incredibly active. He was doing a lot of running, heaps of walking, but also lots of cycling as well. So post-stroke, he was walking with an incredibly like a fixed gait or a fixed knee with straight leg gait. What we were able to do was stim when he needed to clear his foot or have dorsiflexion through the swing phase. However, so that was fantastic and he was really happy with that. But because he wasn't bending the knee or flexing the knee and he wasn't really getting any tibial shank angles, the device actually wasn't able to program itself on him. So what we needed to explain to him was, as I can't be there with him all day, every day to stim every time his foot is going through a gait or going through a swing phase, what we needed him to do was strengthen his quads, strengthen his hamstrings, and get a slightly more aesthetic or slightly more normal gait pattern happening, or consistent gait pattern happening with that little bit of tibial shank angle movement forwards and backwards, so that we were able to program angles. And then that way we would be able to set the program to be able to stim at particular times throughout his gait to be able to have him have that swing clearance. However, he needed to obviously do some rehab before we were able to get to that point, and he did do it, and generally he was an incredibly motivated, fit and active person. So he, maybe 6 months or so later, he was able to move into an ALFESS device or an FES device. So then you've got the normal mode. Normal mode consists of a lot of fine tuning of the gait, and it also opens up a lot more parameters. And what you'll be able to see in there is ramp up and ramp down and the duration of the stim. And you can also set your angle A and B, so when the stim comes on and when the stim turns off. We'll talk about that more in a few minutes. However, we've got those more sort of complex modes there as options, but the one that I certainly recommend the most is the smart mode. So this is an automatic programming mode. All the patient needs to do is walk around 20 meters. The device will start to collect information and collect data, and then create a pattern or an algorithm to know how that patient walks. And after about 5 or 6 steps, it will already be programmed, or it will be on an automatic programming system. And the patient, and it will be stimming at a really good time for that patient. So that is what's called smart mode, and it's certainly the easiest and definitely the one that I recommend the most. We'll talk about it more in a moment. So first of all, you've got the evaluation mode. So the patient needs to walk in a straight line of 30 to 90 seconds. Data will be collected, as you can see there on the page, and then recommended parameters will be determined based on the gait pattern of the patient. You can then choose to adopt the parameters or reevaluate. As you'll see there on that screenshot, you've got the recommended parameters showing angle A of 30, angle B of 7, and then a duration of 1/10 of a second. You can adopt those parameters and then change them, or you can just use them as a guide when you move into your normal mode of programming. So what you've got here in normal mode are the options of pulse width, which remember was like a strength of the stim, the frequency of the stim, which is how many times it happens per second, the intensity, which is a little bit like the volume, how strong or weak do you want it, your angle A and your angle B. So angle A is when the stim starts and angle B is when the stim finishes. Angle A is generally set to about 10 degrees of tibial shank propulsion. And generally that's when we want the stim to come on at like terminal stance. We have the stim stay on through swing until we've got we want heel contact, and then we'll want like foot flat, and that's generally -5 degrees. So before that, the knee is straight. You'll also have ramp on and ramp off, which we're going to talk about a little bit more soon. And then you've also got the duration of the stim. So the duration you can set to 2 seconds, 3 seconds, 4 seconds, whatever you want. However, if you've got angle A and B set, the stim is only going to stay on for the amount of time that the person is between angle A and angle B. If they're a really slow walker and they happen to have the longest swing phase ever, you could use the whole 3 seconds of your duration. But if they're a relatively fast walker, the device is going to pick up their cadence and how soon or how quickly they're transitioning between angle A and angle B. And the stim is only going to stay on for that amount of time. The ramp on and ramp off are adjustments that can be accessed in the Pro version to allow more control in the movement or the dorsiflexion, and then obviously like the plantar flexion of gait. The graph here demonstrates how having a ramp on will allow the gradual increase of the pulse width as the stimulation kicks in. So this will allow for the foot to move into dorsiflexion in a gradual movement rather than a quick and fast movement. This is super beneficial to your patients who have tone or clonus, where you don't want that velocity, where you don't want that dorsiflexion coming on really quickly because it can actually create tone. And increasing the ramp on will give the patients a better outcome. The other thing that you should consider is increasing the ramp off at heel strike. If your patient's quite flaccid and you're noticing a little bit of foot slap because the essentially the stim's turning off a little bit too quickly, it's going from 100 to 0 immediately, you can often get a foot slap happening. So what we might want to do is drag that stim from the peak of its strength and let it just gradually come off. So you may just turn your ramp off to say 2/10 of a second or 3/10 of a second, just so that it's more gradual, and that can just control the foot coming down into stance phase a little bit more slowly and aesthetically. Smart programming. This is obviously my favorite. I think it's an absolute game changer in the FES space. As we discussed, there's an internal sensor which is collecting data. It's a microprocessor which uses an algorithm to calculate when to turn on the stimulation and when to switch it off. So that's judging the patient's angle A and angle B. The stim or the frequency of the stim will slow down or speed up as per the patient's gait speed, and it will pick up a pattern on a consistent walker after 4 to 5 steps. So as long as the patient is starting off their walking with the sound leg first, 4 to 5 steps later, you should start to hear with that beep mode that the stim is coming on in quite a regular pattern. Now, the smart programming isn't designed to do the whole job for you. You definitely need to be able to position that device and be able to select the optimal charge for that patient. So that's talking about obviously getting the position right over the common peroneal nerve and over the tibialis anterior. And then also selecting optimal charge, which is ensuring that you have a balanced pulse width and frequency that is suitable and comfortable for your patient. Once you have those things, the timing and the angles of the stim are actually worked out for you by this smart programming format. I've put there that we have approximately 95% success rate. There are a couple of patients who I've seen who may be a little bit more inconsistent with their walking and may have a little bit of hyperextension at the knee. In those cases, I've moved into the normal programming and just adjusted the ramp up and the ramp down, and sometimes the angle A a little bit as well. If you're working with a patient who has slightly unstable knee, sometimes angle A needs to be increased a little bit so that when they're standing and their knees moving backwards and forwards a little bit, you don't want them activating a stim at that time. So you may just need to increase angle A. All right, moving on a little bit more towards stim adjustments and what are commonly used figures. Learning the language of pulse width. Again, we were talking about that this is the length of the pulse measured in microseconds. And the amount that we're talking here is for one stim, we're looking at anywhere between 150 to 300 microseconds. And then for the frequency, which is the pulse rate or how many times it stims per second, we have between 33, which is a low rate, and 55 hertz, which is quite a high rate. So that's that more buzzing or fuzzing feeling. And then you'll have an intensity. It starts at 0, but you'll generally it'll be functional between a range of 20 to 50 milliamps. And ideally, I like to recommend that a patient is sitting around 30 milliamps. So this is great for battery life. It generally means that the battery will last a lot longer if you can have a balanced stim at 30 milliamps. And it also allows plenty of adjustment for later in the day if that patient does fatigue. So they may be able to, from midday, they may move their milliamps, increase to 35, even up to 40 by the end of the day, so that they're still getting that really nice strong lift and gait swing clearance or foot clearance through swing. Some really, really important considerations to increase compliance are the patient's tolerance to that stim feeling or that electrical feeling, and their comfort level as well. So they need to wear this all day. they want that stim to feel comfortable. If it's hurting them, if it's uncomfortable, why would they wear it? Why would they put up with that? Another quite important consideration is the patient's skin integrity. So in some cases, we do actually have to prescribe a bit of a leg skincare regime, but if the patient does have quite dry skin, and then there's some patients that you may see that may have a little bit dry, some skin may be flaking off, there may be some slight lesions on the surface of the skin, please don't put FES onto that type of skin. You may increase the chance of burning the skin with that electrical stim. So if you do see that, just ensure that the patient uses something that's really mild, like a Sorbeline at night, just to really increase that skin integrity over maybe a week or 2 weeks before you use the stim. Don't get patients to shave. If they ever needed to do hair removal, they could either they could potentially do like Nair, like a hair removal cream to take off the hair. But I think quite rarely the hair becomes an obstruction to the stim. However, if they were an incredibly hairy person, you may need to do some hair removal. And then there's also muscle endurance. So if a patient hasn't been using those particular muscles or nerve for, in some cases, years, they may feel a lot of fatigue early on, and especially after that first initial consult for FES. So just give them that little bit of a warning that they may feel like they went to the gym, the day before, like the day after the consultation. They may feel some muscle fatigue. They may feel like they went to the gym. They might feel a little bit unusual in that leg and ankle because it has moved in a way that they're not used to. With bilateral programming, you've got 2 options. So basically, one, you can program one device at a time with one phone, and I would always suggest programming the strongest leg first in that case. And then secondary to that, you can program 2 units at the same time. However, you would need to use 2 phones in that case, as unfortunately the phone app can simply only connect to 1 unit at a time. Some gait mode prescription ideas here. So if you're looking at a pediatric patient, and I've just guessed that this would be around under 8 years old, you'd be looking at using a frequency of 50 plus, so something that's very buzzy, light and fuzzy, and a pulse width of anywhere around 100 to 150. And that's where you would hope would be comfortable for a patient that young. However, I think there needs to be a fair bit of familiarity with the device prior to putting it on them, because to feel that buzz initially can be really confronting and a really strange feeling. So I think, just take it really slowly with those pediatric patients. A youth patient, so this is sort of 8 and above, frequency of approximately 50 and then a pulse width of 150, and you can move up from there, is recommended. A female adult, or simply like a person with a small leg, you look at a frequency of 40 to 50, and a pulse width of 150 to 200, but I think more like 200 is where you would start with a small leg. And then, so that is obviously to get a good movement or a good dorsiflexion result. And then I've said male adult, but really this is just a large leg. You're going to want a lower frequency, so 30 and maximum 40 frequency, with a pulse width of starting at about 200 and moving up from there. Wearing in, so with all orthotics, we want to have a gradual increase of wear, and the wear time for the ALFESS is laid out here in this table. You've got the first week, second week, and third week, and they're on after. So just gradual wearing in. So they recommend that training mode is used every day. at least twice a day, so morning and evening. And then if they are doing walking, that it may start off just as 15 to 60 minutes a day at the beginning in that first week, and then hopefully after the third week they're able to use it for that whole day. And as we have mentioned, you may ask your patient to try to start the day off at a lower intensity and increase it later on in the day if they do fatigue a little bit. It will also be better on the battery life. And I do recommend that if the strap is uncomfortable initially, because it's just an unusual feeling and some people can be a little bit tender around the fibula head. If the strap is uncomfortable, you can certainly add some padding under the strap and to try and sort of offload any sensitive areas. Hydrating moisturizer can be used the night before, but it should be washed off prior to use, and definitely avoid using the ALFESS or any FES device on sunburnt skin. All right, as we mentioned, there's a whole user manual to the remote control itself. And on a couple of occasions, again, as mentioned, units have been out on trial, but they haven't actually been connected to the patient's phone. Somehow the beep mode has been turned on. This is potentially due to like a sitting on the remote or bumping the remote. We've had to remotely. So over the phone, we have had to discuss with the patient how to connect into the remote control to actually turn off the beep mode. Thankfully, that's worked really well, but it does just offer another option, for the patient, for the clinician to program, and for the patient to do their increases or decreases of intensity throughout the day and change some of the settings if required. We're moving on to some troubleshooting now. Consideration 1. What if the patient's leg is not getting enough lift, or patient's foot is probably a better way of putting this. So there are a few things that you can do, but initially you would maybe increase the intensity. And if the patient can't tolerate that increase of intensity, you'd maybe move the placement or the positioning of the device a little bit further down to be more central over the tib and belly. And Allard always recommends that you don't do any movements that are more than 5 millimeters at a time. I think it's a good recommendation because if you've got a successful position, you don't want to lose that successful position. If you're only moving a tiny little bit at a time, it means that you're going to have a better chance or a faster chance of getting back to the that initial position or that good position that you wanted. If a patient has spasticity, it would be beneficial to lower the frequency and increase the ramp on. So that would mean moving back into that normal mode and just looking at your ramp on and potentially increasing it to say 0.3 of a second. What if a patient presents with too much supination and they can't tolerate the milliamps or the intensity due to the pain? So the first thing to do is lower that pulse width, remembering that the pulse width is a really big power or strength to the stim. So if you lower it, it generally should be more comfortable, but it would give less intensity or strength to the stim. So if you were getting a really good dorsiflexion moment, if you decrease that pulse width, your dorsiflexion may not be as rewarding afterwards. So lowering the pulse width would allow more intensity but less pain. If the supination persists, change the position of the cuff by rotating it laterally. And again, we don't recommend moving it more than 5 mil at a time. What if the patient requires posterior electrode placement for eversion or perineus activation? So in my experience, I've come across quite a handful of patients who have multiple sclerosis who require an incredibly posterior electrode or a stim into almost the popliteal fossa to engage or to hit that common perineal nerve and the superficial branch to create eversion. With the ALFESS, the electrodes are predetermined in their position. and they're non-movable. The other feature of the device is that it runs on the sagittal plane angle, which is, moving forward and back, moving forward and back. If you twist the device right around to get that posterior activation of the common perineal nerve, what you're essentially doing is changing the plane like the anatomical plane that the device is sitting on. And by the time you've turned it so laterally, you've turned it onto the coronal plane, which actually means that as the patient's walking forwards and backwards, they're not going to be hitting angle A and angle B. So the device is not going to know when to stim. What I'm saying is the device is not set up to support patients requiring a really posterior electrode position. There are some other devices on the market that would be able to accommodate those positions. However, the way that you would use the ALFESS in this particular, or one way that you could use the ALFESS in this particular event is by using the training mode, and using the training mode whilst the patient just sits, like I said earlier, on the couch or just in a chair relaxing. They can still use the training mode to get tibialis anterior activation, to get dorsiflexion, and also to activate the common perineal nerves and get that eversion. However, it's not going to work in a functional way to lift the foot into dorsiflexion through the swing phase of gait. And then slightly similar, what if the patient has a tight Achilles and can't clear the foot through swing? So this was another patient who was living with multiple sclerosis that I saw. Is we were getting great eversion, but we weren't able to clear the foot through gait due to her just having such a tight Achilles. She had been in plantarflexion, she'd been walking in plantarflexion for so long, her Achilles had become so tight. However, we could see potential there. So a little bit like that analogy that I had earlier with the patient who had had a stroke and needed about 6 months to just do some rehabilitation work prior to be able to using an FES device. This patient is currently doing some rehab, definitely stretching out those posterior leg muscles and using the ALFESS on a trial, but mainly using it in training mode just to continue, and using it really anteriorly on that tibialis anterior muscle to get lots of dorsiflexion. And as far as I know, she's using it, or it was prescribed to her to use the training mode for 20 minutes 3 times a day, so morning, noon and night. Pardon me. And with the hope that, or with the aim that she would stretch out the Achilles, and further down the track we would be able to put the ALFESS on her and get some really good dorsiflexion and of course clearance through gait. Some frequently asked questions around the ALFESS device. What is the warranty? So we've got 2-year warranty on the device. There have been minimal warranty claims for the ALFESS over the past couple of years that we've had it. Repairs for the devices are not available, as we discussed earlier in the presentation. It's a contained unit, so if we were able to actually take it apart and do servicing, we would be voiding the waterproof certification. So we do replacement only. However, Allard have been fantastic in the couple of replacement devices that we've had. Maintenance is required, and it's just regular cleaning from the patients themselves, ensuring that it's nice and clean, that the charging port is clear, and that charging is happening as required. So if the patient puts it on overnight, it certainly should be at full charge by the morning. OPC Health have a loaner program. We have units available for short-term loan, and please contact us for details if you would like some loaner units. Workshops, we've started our face-to-face workshops for 2024. These are certainly available in all parts of Australia with probably, I'll say, 4 weeks notice. We do need a fair bit of notice if we're going to be travelling interstate to do face-to-face workshops, but they're certainly available. along with like Teams meetings, Zoom meetings and workshops, and also FaceTime consultations have been fantastic over the last few years, to be able to meet with the patients remotely, but also do some prescriptions and reviews for patients who are wearing their FES devices. So we've been able to do that over the phone, which has worked really successfully. And that brings us to the end of the presentation, brought to you by OPC Health and OPED Australia. And if you have any questions, of course, you can get in contact with us. And you can certainly contact the orthotics at opchealth.com.au, email and get in touch with the orthotics team if you've got any questions after this presentation. And thank you very much for your time today. All the best at Opal and OPC Health, and hopefully we see you again soon. All the best.